My name is Nida. I am currently one of the third-year internal medicine residents. It is my great pleasure to introduce three distinguished speakers today for our grand rounds. The first is Dr. Raul Mitrani. He's one of our fantastic cardiologists. Dr. Mitrani completed his internal medicine training at Columbia University in New York before heading to Case Western to complete both his cardiovascular fellowship as well as his electrophysiology trainings. Dr. Mitrani has been at the forefront of managing and treating cardiac arrhythmias using catheter ablation since the early 90s. He has been doing incredible research throughout his career and has participated and spearheaded multiple clinical trials at the Interdisciplinary Stem Cell Institute. His interests have expanded to include mid and long-term cardiac and arrhythmic effects from infection in COVID-19 patients. He currently serves as the director for our Electrophysiology Fellowship here at the University of Miami. The second speaker is Dr. Shweta Anjan, who after finishing her medical school in Manipal, India, completed her internal medicine residency at the University of Pittsburgh. She then left the cold to join us here in Miami for both her infectious disease fellowship and her transplant infectious disease fellowship. Dr. Anjan is currently part of 5 separate clinical trials with focuses from HIV-positive deceased donor organ transplants for HIV-positive recipients to trials analyzing the efficacy of convalescent plasma for patients with COVID-19. She currently serves as an assistant professor of clinical medicine for our infectious disease department. Finally, last but certainly not least, we have Dr. Folusakin Ayoade, who after completing his medical school training in Nigeria, finished his internal medicine residency at SUNY Downstate in Brooklyn, New York. He then moved to Shreveport to complete his infectious disease fellowship. Dr. Ayoade has numerous publications, book chapters, and conference presentations. And this year alone, Dr. Ayoade has managed to secure 2 large grants to help fund his research. One project is focused on understanding the performance of a cerebrospinal assay in a tertiary hospital setting, and the other is a phase 2 clinical trial on the efficacy of an antiviral drug, favipiravir, in patients with COVID-19. He currently serves as an assistant professor of clinical medicine for our infectious disease fellowship. So without further ado, I'll give it over to Dr. Mitrani.
Thank you, everybody. It's my pleasure to be here. I've been with the University of Miami now for 25 years, most of it as faculty, and it's an honor to talk to you about one of our current research projects. And I congratulate all the residents who applied to fellowships. In the last few minutes, they found out where they're going to spend the next 2 to 4 or 5 years of their lives. And my advice to you is if, in terms of the fellowship program, you just found out where you're going. If you're not with the one you love the one you're with. With that, we'll go ahead. So COVID-19, I think you've all read about, heard a lot about its course. Thankfully, most of our patients have mild courses. A lot of them apparently don't even know they have it. And most patients still are not diagnosed, at least formally, by testing, according to the CDC. However, some of them do have severe courses, and we thank our ICU and hospitalist staff and resident staff for taking care of them. And what we're going to focus today is the recovery phase of the COVID-19, in particular, the cardiovascular effects. So this is an early study of myocardial localization of coronavirus in a patient with cardiogenic shock who had electron microscopy from a biopsy specimen showing the actual COVID particle. You nicely see the spike protein around the COVID particle kind of embedded in the myocardium in a cell or in the cell surface. So we do know that the COVID-19 particle has tropism for myocardial through the ACE2 receptor, but we're not going to talk about that because you've heard a lot about that, and many of you probably know more than I do about the receptors. Anyway, but I do want to talk about is that there are multiple mechanisms whereby there can be myocardial injury. Direct viral invasion is probably low in terms of the frequency of how the myocardium becomes inflamed or injury. A lot of it has to do with either type 2 MI, where there's an oxygen supply-demand mismatch. Some patients present with acute ST segment elevation MI. There can be thrombotic embolic effects. The hyperadrenergic effect can cause myocardial injury. There are microembolic infarcts as well. We all know about the cytokine storm and other mediators that can produce a pro-inflammatory state. Of course, there's an autoimmune response. All these, either singular or in combination, can cause myocardial injury, either a myocardial infarct, microinfarcts. It can lead to ventricular fibrosis or atrial fibrosis. And this can all then evolve in the long term, in the recovery phase. This is what we're concerned about. Ischemic cardiomyopathies, non-ischemic cardiomyopathies. There could be subclinical systolic or diastolic abnormalities. Patients, if they have fibrosis in the atrium or ventricle, can have arrhythmias, whether they're premature ventricular complexes or ventricular tachycardia. This may leave them at risk for sudden cardiac death. And they can also have atrial fibrillation. So this is what Drs. Goldberger and Dobbs and myself wrote about in an article a few months ago, that now was the time to really start looking for a post-COVID-19 cardiac syndrome. So Dr. Hare and colleagues wrote an article on inflammatory cardiomyopathies in terms of the different etiologies. Certainly, of viral infections is a large etiology that can cause myocarditis. There's interplay between host factors, genetics, host factors, autoimmune, and the actual infectious agent, which kind of leads to what the response and what the sequelae will be. So certainly for COVID-19, this plays a role, because we see patients who are totally asymptomatic, still a fair number, but we see even very young and healthy patients who can have bad courses, not only acutely, but also in the long run. So in terms of myocardial injury, acutely, this was one of the largest studies published to date, looking at about 2,000 patients in the Mount Sinai system in New York who had positive troponins. And this involved 36% of their total cohort of hospitalized patients with positive troponins. And they nicely mapped the outcomes based on the level of the troponin rise. So if you see in the top graph, for those patients who did not meet the criteria for elevated troponin, there was a mortality of about 5% in their total population. When they had the intermediate group and the elevated and the highly elevated troponin group, we see that the mortality substantially elevates. So having elevated troponin, we've known, is a very bad prognostic sign. It predicts mortality, it predicts ICU time, it predicts mechanical ventilation. But what about in the long term? So patients go home. Thankfully, we have great doctors here. We have great doctors all over the country. They go home. Are they done? Well, we find out from the late press that we're not done. So this is an early report from August of a pitcher who was out for the season with a post-COVID-19 cardiomyopathy of sorts. So we have to look at other viral myocarditis to kind of get a glimpse of what to expect from COVID-19. And now we have some early data in terms of what COVID-19 is doing to patients in the recovery phase. So in patients recovered from viral myocarditis, 1/3 or more may be left with chronic heart disease, heart failure, or cardiac arrhythmias. In patients with COVID-19 related cardiac injury or myocarditis, it's really unknown how many will fully recover or have ongoing cardiac problems. Will they have mild or severe heart failure? Could they have cardiac arrhythmias, atrial fibrillation, ventricular tachycardia? Could they be at risk for sudden death? Could some of them have subclinical myocarditis or subclinical cardiomyopathy, which could present a risk for them? So there was an early study which created a stir all over the world, really. I mean, this study was noted in many broadcasts, CNN, Fox, other news outlets. And what they did was this study was from Germany. They took 100 patients recovered from COVID-19. Only 33 were hospitalized. So the paradigm before this study was probably the sicker patients are the ones going to have a problem. Personally, I wasn't even going to look at the non-hospitalized patients until this study came out. And what they found was that they had troponin elevation 71% and significantly elevated in 5%. And these patients were several weeks out after their COVID-19 infection. The post-recovery cardiac MRI scan revealed cardiac involvement in 78% and myocardial inflammation in 60%. And the findings were independent of pre-existing conditions, the severity, and or the timing of the actual cardiac MRI scan. The patients were compared with 2 levels of control. There was a healthy control group, I guess from their database, and there was a second group of risk factor matched controls, as I'll explain in the next slide. So one group was healthy controls, one was risk factor matched. So you see the mean age was around 48, 49, about half male, half female. The BMI was reasonable. Hypertension, 22%. So here's where the risk factor matching comes in, and pre-existing CAD was 13%. And what they found was in the COVID-19 patients, the ejection fraction 56%. You ask any of us, 56%, okay, that's normal, that's fine. But it was slightly lower than the healthy controls and the risk factor match controls. But this is not prospective, so it's really hard to evaluate that. The end-diastolic volumes, again, nothing particularly high. There may have been some outliers, but the mean was a little bit higher than the healthy controls and the risk factor match controls. And same thing with the right ventricular ejection fraction, just a little bit down compared to the healthy controls and the risk factor match controls. So they found abnormal T1 imaging, and I'll explain that in a minute, in 73% of the COVID patients, abnormal T2, which is more specific for edema, in 60%. You didn't really see that many abnormalities in the healthy controls, but if you look at the risk factor match controls, you see now that they also have abnormal MRI findings. They found late gadolinium enhancement in the myocardium in 32%, and interestingly, in the pericardium is 22%. You're going to see that COVID-19, it does affect the pericardium. And that was also significantly more than the other two groups. But it's not like the risk factor match controls were at 0. They also have some subtle MRI abnormalities. So increased native T1 measures represent diffuse myocardial fibrosis and or edema. T2 is specific for edema. Patients with increased native T1 and T2 have an active inflammatory process. An increased native T1 and normal T2, we're usually dealing with residual diffuse, healed residual diffuse myocardial damage. So there was another study that looked at MRI scans in patients. This was from Wang, recently published in one of the JACC imaging journals. And again, they did MRIs 47 days after their diagnosis in the study by Putnam, which I just presented. So the bottom row I had just presented the data in detail. And they also found 58% abnormal MRIs. 54% had abnormal T2, which is edema, and 31% had late gadolinium enhancement. In their study, the right ventricular ejection fraction seemed to be more affected. They measured it at 36%. And that was specific for those patients with abnormal MRIs, not for the patients with normal MRIs. And they found pericardial effusion or abnormalities in 27%. So what we see here is that the COVID-19 may lead to some MRI abnormalities above to what you might expect to risk factor controls. But risk factor controls also have some abnormalities, so it's going to be difficult to interpret what's specific to the COVID-19 and what might have been pre-existing. So this is an algorithm Jeff Goldberger and I recommended. And actually, I modified the algorithm from the time it was initially published in the journal. And we think acutely all patients should have measurements of their troponin and BNP. If it's elevated, they should look for a ST segment elevation MI and then treat appropriately. Otherwise, if there's no injury pattern, they should have standard imaging and therapy as clinically indicated. And then we recommend maybe ECG and an echo with strain for those patients, particularly those with elevated baseline troponins, but even to consider it for other patients. And then to consider cardiac monitoring depending on symptoms. And if these are abnormal, then maybe go to an MRI scan. Now the algorithms are still evolving. This was kind of our paradigm of how we would react. but we're going to present some data, and we're going to present data specifically on athletes. And why athletes? Because athletes are more likely to do well during acute infection. Obesity and age are risk factors for morbidity and mortality, and this is generally not an issue for our athletes. Preliminary studies in non-selected patients following COVID-19, as we discussed, shows high prevalence of myocardial edema, pericardial inflammation, effusion, RV abnormalities, late gadolinium enhancement. So athletes, and it's not just specific to competitive athletes, but those who push themselves and train a lot may be at particular risk for cardiac complications given their high level of physical activity in the setting of myocardial abnormalities. So what's been published so far? Not much, but there is some. There are a lot of guidelines and consensus statements. The Stanford Hall consensus statement stated that for athletes, this came out of a group in England. It did not come out of Stanford University. They recommended 3 to 6 months convalescence for any athlete with myocarditis post-COVID-19, periodic assessments for up to 2 years, and they recommended training competition to resume after biomarkers and imaging returns to normal. And again, that's an opinion base. But they also said, interestingly, cardiac sequelae should be considered in all patients post-COVID-19, regardless of severity, and all patients should have an assessment of their cardiac symptoms, recovery, function, and potential impairments. So what's been published on athletes so far? So there's one study from Rajpal out of Ohio State University, 26 student athletes, 12 with mild symptoms, all had normal troponins in the recovery phase. Okay, none of them were hospitalized. They did MRI scans on all patients, 11 to 53 days after, had abnormal MRI in 46%. The edema, which is a marker possibly of myocarditis, or probably of myocarditis, was found in 4 of the 26, or 15%. And they found late gadolinium enhancement, 46%. So we're going to have to discuss that. And RV function, they measured to between 49 and 66%. And Brito had a study out of West Virginia University. And again, they had only one patient with elevated T2, so myocardial edema or myocarditis. I didn't see any reports of their late gadolinium enhancement. I think they had, the one patient with the edema also had late gadolinium enhancement, and their RV function was a little bit down as well. But they found late enhancement in the pericardium in up to 40% of patients. A lot of their patients had pericardial effusion. So we're getting slightly discrepant results. So the one issue before I give the Miami results is the MRI too sensitive? Abnormalities in the cardiac MRI may be due to athletic, heart, and physiologic adaptation. And there are differences between endurance versus resistance training. And how are we going to distinguish cardiac MRI abnormalities due to COVID-19, possibly indicating myocarditis or other injury versus non-COVID-19 etiologies? So this is well described that athletes, both males and females, tend to have somewhat lower ejection fractions, higher ventricular mass, higher volumes in both the left and ventricular and diastolic volumes. Interestingly, late gadolinium enhancement, typically in the septum, kind of in the insertion points where the RV inserts, was seen in 35 and 41% of athletes. And these results have been found in many other athletes. Pericardial fusion was seen rarely in males in this one particular study, but they saw it somewhat more often in females. But
3 minutes, Raul.
Got it. 3 minutes. So I'm going to skip these slides and go to. So we got together with a task force of electrophysiologists, sports medicine doctors, physiologists, and myocarditis experts, and our fellow to put everything together to start the Miami protocol, multidisciplinary inquiry of athletes in Miami in COVID-19 recovery. And basically we tested biomarkers, ECG, metabolic stress testing, rest stress echo with global longitudinal strain. And we only did MRI scans when there were clinical abnormalities. We have a total of 56 athletes, both professional and student athletes, split between baseball and football and some others. And our findings so far is that we found normal troponin and BNP in all patients, mild elevation in CRP in 3 patients. ECG and echo is consistent with athletes' hearts in many patients. We found deconditioning with diminished peak maximum VO2 in a bunch of patients. I can't tell you if that's COVID-19 or just deconditioning. 11 were referred for cardiac MRI. 2 of these patients have confirmed myocarditis and are under treatment with Dr. Hare. 1 patient had abnormal MRI, which we deemed to be athlete heart with late gadolinium enhancement in one of the insertion points. So overall, 3.5% of the patients were diagnosed with myocarditis and appropriately are not allowed to exercise or train or compete. So putting our protocol compared to the other protocols, we are finding abnormal MRIs in those that we MRI, but remember, we're not doing MRI scans in all patients. And we did find pericardial effusions in a small number of patients, typically the ones with the myopericarditis. And RV function, we're finding it down in the 2 patients with the myocarditis, as well as in 1 additional patient. So the Miami protocol is open to everyone. We're continuing to evaluate competitive patients. It's open to all athletes, recreational and otherwise, recovering from COVID-19, either with a positive troponin during index hospitalization and or lingering symptoms that may be attributed to the cardiovascular system. We're also doing it for non-athletes if we think they may have some COVID-related cardiac dysfunction. So in conclusion, the novel coronavirus may cause overt or subclinical cardiac injury and or inflammation in a significant number of patients. There's still a lot of work that needs to be done. Risk factors, incidence needs to be carefully defined. The optimal protocol needs to be defined. We don't think we should do MRI in everyone for the problems I elucidated earlier. And we're doing risk stratification of athletes, both recreational and competitive, since it's critical to identify those small numbers with myocarditis to prevent them from, God forbid, get a sudden cardiac death event. Thank you. I'm open for questions.
Yeah, that was really excellent, Raul, and I'm sorry I had to rush you, but I didn't realize that ID actually split their 30 minutes with 2, and I thought everybody had 20. So we have a few minutes for questions, so that's great. This is a really important topic that has major societal as well as financial implications in terms of the pandemic and understanding what it will do to such an important sector of our economy and sports. Let me begin the questions perhaps by, how does one determine what the right and appropriate time frame to evaluate these patients really is in order to assure safety?
Sure. So for athletes, they have a mandatory 2-week period of no exercise, no competition, no training. Jeff Goldberg actually did analysis of one of the studies published from Ohio State University where they had 4 myocarditis. And it's like 2 out of the 3 myocarditis were in patients who had their MRI scans before day 14, and 2 out of the other 22 or so had it after day 14. So we don't want to analyze them too early, and our protocol is to analyze them at least 14 days after their positive test. Plus, they have to be asymptomatic, of course. If they haven't continued symptoms, then we would ask to wait until they recover.
Fantastic. Dr. Dickens, do you have a question? How about Dr. Saxena? You put something on the chat. Would you like to ask it, please?
Yeah, I actually have a lot of young adults, a few months out of COVID infection, most of them non-hospitalized, who are still having a lot of symptoms of palpitations, dyspnea on exertion, like poor exercise intolerance. A couple of them I've done like Holters and echoes just because the burden seemed really bad, and they've had like some slight abnormalities, but nothing that I would jump up about. I don't really know, should I be referring them to cardiology for further evaluation then, or is it more of like a watchful waiting, or we don't really know?
So we don't know, but if we're going to assess, we like to do a stress component, especially for the younger and healthy athletes, as you point out, to see what their functional capacity is. Some of it, or a lot of it, may be deconditioning, but we also do a technique called strain with the echocardiogram, which looks at the muscle and can detect some subclinical abnormalities of myocardial contractility, even in patients who have normal ejection fraction. Let me point out that our two patients, student athletes who had myocarditis, had normal ejection fractions at baseline. So ejection fraction is not it. You need to look kind of more deep into this situation. Now, what we found in my non-athletes when I'm seeing them is there's an interplay between autonomic dysfunction, and a lot of them get fatigue. And I actually spoke about this to Nancy Klimas, who runs a very a big chronic fatigue center in Broward County. She used to be on faculty here. Plus, there's an interplay with pulmonary symptoms. And as most of you know, there seems to be lingering pulmonary fibrosis or pulmonary infiltrates that can take some time to resolve. But yeah, if you think they're having still cardiovascular symptoms, what we would do is do the biomarkers. It seems that the CRP is the most sensitive. And then we would put them on a treadmill and do this echo with the strain and see if there's any abnormalities.
Thank you very much. That's great. Let's move on to our next speaker.
Good afternoon. Let me please share my screen. Thank you for the opportunity to present this grand round. I'll be talking about antibiotics for COVID-19. Are we over-prescribing? I have no relevant disclosures or conflict of interest. As you are well aware, COVID-19 cases are going up again, and of course, with increased cases come increased hospital admissions. As you can see from this graph from the COVID network, you see how the numbers are going up, especially in people above 65 years of age. Unfortunately, with increased hospital admission come the increased need to use antibiotics. Here are my objectives. I want to talk about the magnitude of antibiotic use and the risk of bacterial co-infection in COVID-19. I will discuss briefly about the role of procalcitonin in determining bacterial co-infection in COVID-19 and help us to understand what factors we should consider before prescribing antibiotics. So antibiotics for COVID-19, what is anxiety? Why do doctors prescribe so much antibiotics? Well, there's clinical uncertainty about a coexisting bacterial infection. You're not really sure whether this case you have in front of you is viral pneumonia or bacterial pneumonia. And of course, as providers, as physicians, there's that urgency and pressure of doing more than less when you are faced with that particularly ill patient whose life hangs in the balance. And this is not far-fetched because we know there is high mortality in those who end up developing bacterial infection, they end up dying of COVID-19. So talking about COVID-19 and antibiotic use, earlier in the pandemic, I was involved in a survey that involved over 160 participants from 23 countries and 82 hospitals, including our own UMH and Jackson Memorial Hospital. We kind of focus on people who are the front line taking care of COVID-19 in the hospital, i.e. doctors, critical care providers, and hospitalists. And what we found was that there was a widespread antibiotic use in patients who are in the hospital with COVID-19. And actually, North America was the most frequent user of macrolide and cephalosporins, which are, of course, one of the FDA-approved options for hospital-acquired treatment of pneumonia in people who are admitted. We published our finding in Journal of Antimicrobial Chemotherapy. Here is a table from our manuscript. As you can see, we have the countries on the columns and the antibiotic options in rows. The first was asking, we do not routinely prescribe antibiotic to patients in the world. United States responses was 0. Other countries have something showing that in the United States and Canada, it seemed like almost everybody, at least at this time in the pandemic, almost everybody in the hospital with pneumonia did get antibiotics. These are other key findings from our survey. we show that 62% of participants, even though they reported that they have guidelines for COVID-19, those guidelines did not differ from the local community acquired pneumonia guidelines. And when you asked what was the number one reason to provide antibiotics, after clinical presentation, the next was increased procalcitonin. And then when they start antibiotics, what are you trying to cover? Atypical organisms was the number one reason. And of course, we know from some recent publications, and the one that was, of course, published in Stanford, California, earlier in the year, showing that a lot of patients who are in the hospital with COVID-19, atypical bacterial organisms were not really frequent at all. With mycoplasma, only a few, and chlamydia, probably none in all the cases they reviewed, over 1,000 cases. So it's not only our studies that show that there was widespread antibiotic use in COVID-19. There's a single center retrospective analysis of over 240 patients in ICU and non-ICU setting, showing that 67% of them got antibiotics, yet 72% of them did not have any source of bacterial infection. Of course, there was very high rate of mortality in those who got antibiotics compared with those who did not. What about this meta-analysis of 24 studies looking at about 3,300 patients admitted with acute bacterial infection? 72% of them, of course, got antibiotics. And then this multi-center evaluation of 246 US acute facilities looking at patients who presented acutely either in the emergency room or urgent care setting with COVID positive and COVID negative. We found that even 68% of those who are COVID positive did get antibiotics, but 45% of those who are negative also got antibiotics. So that tells you that there is that very low threshold to provide antibiotics when patients come to the hospital because of COVID or in a COVID pandemic era. And of course, in this study also, the most commonly used antibiotics were third and fourth generation, just like in our survey. So this excessive antibiotic use was noticeable by the media, with several news outlets kind of warning against excessive antibiotic use among healthcare providers, with WHO sending out a warning in June against overuse of antibiotics, which might actually cause more deaths because of increased development of resistant bacteria. So now that we see that there was widespread antibiotic use, so how really common is bacterial infection in COVID-19? I will just share results from 3 meta-analyses. The first one is look at 2,000 patients and found that only 8% got bacteria or fungal co-infection, even though over 70% did get antibiotics. The next one, look at 3,800 patients in the hospital with COVID-19, only 7% actually had bacterial co-infection. Of course, as you can expect, people who are in the ICU setting, a higher proportion did get antibiotics. And the last one is also looking at over 3,000 patients, showing that only 6.9% had bacterial co-infection. Of course, if they're in the hospital for a longer period of time, the number goes up. So when you put all this together, we can say that true bacterial infection in COVID-19 is not common, probably 6 to 8%, and does not justify the wide use of antibiotic therapy. What about other co-infection in other coronaviruses before COVID-19? We put everything together, only 11% of bacterial co-infection in other coronaviruses, with the highest being SARS-CoV-1. But even in this setting, you can see that there was widespread antibiotic usage. The risk or implication of excessive antibiotics, I'm sure we're all aware of that, ranging from disruption of antibiotic stewardship program to antibiotic side effects, C. diff colitis, prolonged hospital stay. Antibiotics, of course, they are not all that safe. I mentioned earlier that procalcitonin was one of the reasons why a lot of providers give antibiotics. And this is not far-fetched because in bacterial infection, as we know, increased IL-1 beta, increased IL-6 and TNF alpha is elaborated, and that leads to release of procalcitonin from extrathyroidal sources. But in viral infection, however, with the interferon gamma, that inhibits interleukin-1 beta and TNF alpha, and that leads to less procalcitonin. So that is what we know before COVID era. But it seems like procalcitonia has been overemphasized because there are a lot of other conditions apart from bacterial infection that can cause increased procalcitonia. As you can see in the table on the right side of this slide, a lot of non-infectious inflammatory conditions, trauma, even when there is infection, it's not only bacteria, sometimes parasites, severe viral infection, they can all cause increased procalcitonia. So how should we interpret procalcitonia in the setting of COVID? This is the result of a meta-analysis looking at 4 closely related studies showing that the odds ratio of elevated procalcitonia is about almost 5 times, increasing the risk of severe COVID-2 infection. Meaning when you have increased procalcitonia, it correlates almost 5 times with the severity of SARS-CoV-2. So we can say that increased procalcitonia by itself does not mean that there's a bacterial infection, but it means what you are dealing with could be a case of severe COVID. And several papers have also published similar results. In the setting of COVID, this important paper published in the CID in August showed the predictive value of procalcitonin and showed that as providers, we should use procalcitonin probably in this fashion, rather than if it's elevated, you have infection. If it's not, you don't have infection. So from this paper, it showed that the positive predictive value of procalcitonin more than 0.5 was merely 9.3% to predict the onset of community-acquired bacterial infection. In contrast, when the procalcitonin is less than 0.1 nanogram per ml, the negative predictive value is actually 98% or more. So that means that when the procalcitonin is really low, when you put that together with other factors, you can conclude convincingly that bacterial co-infection is probably very unlikely. So talking about antibiotic guidance for COVID-19, unfortunately, we do not have a lot of solid guidance out there about what we should do as providers. For example, the NIH gives us no guidance. Even the IDSA, we don't have any clear guidance of what we should do. Should we give antibiotics? When should we give? How should we give? CDC only gives us a statement and just says that, okay, the decision to give antibiotics should be based on the likelihood of bacterial infection, illness severity, and you should, of course, employ antimicrobial stewardship guidelines, but nothing concrete about what to do and what not to do. The WHO kind of gives us some interim guidance and kind of categorized into mild, moderate, and severe. And it says for mild COVID, people who have COVID symptoms but no respiratory involvement, no hypoxia, X-ray is fine, do not give antibiotics, either for treatment or prophylaxis. And therefore, people with moderate COVID, people, they have respiratory symptoms, but they are non-hypoxic at room air, that you should not give antibiotics unless you have a strong clinical suspicion of a bacterial infection. And of course, for folks with severe COVID, probably it's reasonable to give antibiotics, but even when you do that, you should de-escalate early. So I found this quite useful. Is the nice guideline, the National Institute of Health and Care Excellence. This is one of the executive public body of the UK Department of Health, responsible for guidance in clinical practice and other relevant health matters. And over the course of the pandemic, they have released 22 COVID-19 rapid guidelines, and this is one of them, kind of giving us advice on what to do for folks with pneumonia who are admitted into the hospital. And I will refer the audience to check on this at your downtime. Give us a lot of advice about what to prescribe, when to prescribe it, when to stop. This is an example. They gave us an example of tests to do, if you are not sure whether you should give antibiotics or not. And some of this we already do, like cultures, look at full blood counts, urine antigens for Legionella and pneumococcal, and of course, chest imaging. How does chest imaging help us to make a decision whether or not there is bacterial co-infection? A lot of papers, but I found this quite useful from one of the early one series that look at 975 CT scan results. Of course, CAT scan is more is superior to chest X-ray in giving us advice whether or not there is to just guide us into what we're dealing with. And for people who end up having only COVID pneumonia with no other bacterial infection, they found that the two commonest pattern on chest CT were ground glass opacity and bilateral patchy shadowing. Both of those are above 50%. Of course, there could be other findings like local patchy shadowing or peripheral infiltrate. But if you put all this together, you could make a conclusion whether or not what you're dealing with is bacterial pneumonia or just viral pneumonia. So putting everything together, this is like a summary slide. I think we should look at deciding what to do about this. We should look at the clinical setting, ICU versus non-ICU setting. For people in the ICU or people who are sick or on pressors or are intubated, I think the threshold should be quite low, and then you can de-escalate, because we know people in the ICU do poorly. And most of those people who die of COVID are those who develop secondary bacterial infection. Secondly, as I said, look at the chest imaging pattern. Does it have a characteristic patchy shadowing or ground glass opacity? The role of procalcitonin, again, is probably useful as a negative predictive value to rule out COVID rather than to rule in COVID. And then, of course, something can substantiate the clinical judgment of the provider. And if you start antibiotics, you should try to de-escalate early, of 5 days or less in most cases. In the future, I think we need prospective evidence to support development of antimicrobial policy for COVID-19. And of course, we do need appropriate stewardship interventions that is unique for the COVID-19 pandemic, which currently we do not have. This is my take-home message. COVID-19 is caused by a virus. Concomitant bacterial co-infection occur in 8% or less. A majority of patients can be safely managed without antibiotics. Again, procalcitonin, I think, is useful to rule out COVID rather than ruling COVID. Thank you.
Thank you, Dr. Ayoade, for that wonderful presentation. Because of time, we'll go on to the next speaker, and anyone who have any questions can put them in the chat. Thank you. Go ahead, Dr. Anjan. We see your slides.
Oh, perfect. Hi, everyone. This is Shweta. I'm one of the transplant infectious diseases physicians. And today I'm going to go over some of the challenges and nuances we have with managing COVID-19 and solid organ transplant recipients. I have no disclosures. The objectives of this talk is to evaluate impact of COVID-19 on solid organ transplantation, discuss risks associated with organ transplant and measures taken by all the transplant centers, review data on risk factors, management, and outcomes in solid organ transplant recipients. So to assess impact of the pandemic on organ transplantation, you would need some numbers to begin with. So in 2018, there have been over 1.5 million organ transplant recipients worldwide. In 2019, this is data only from the US, there were about 40,000 transplants, 120,000 waitlisted, and 10,000 waitlist mortalities reported. So the numbers in 2020 we are yet to find out, obviously, but what we can say for sure is that the COVID-19 pandemic has negatively impacted organ donation and transplants worldwide. Data obtained from the national organ procurement organizations in France and from UNOS in the US show that there has been a 51% reduction in deceased donor transplants in the US and 90% reduction in France from early on in the pandemic. This mostly impacted kidney transplants, and in the past 6 months, based on data reported till June, the waitlist mortality in the US has increased by 26%. So what are some of the risks associated with organ transplant? There is a potential for donor-derived infection, in theory, because there is transmission of viral RNA reported through body fluids and possibly in organ tissues, but that has not happened so far. In fact, there's a small case series of 6 patients who received organs from COVID-positive donors with no transmission. Also, I think the American Society of Transplantation and organ procurement organizations are now doing an excellent job with screening donors. There's concern for exposure to healthcare and organ recovery teams who also have to travel to other hospitals to recover organs. There's possibility of disease transmission through transport material, we also have to face the possibility that we have to consider availability of PPE and hospital resources, especially if your transplant center is in an area with a COVID surge. What is important, though, is that we weigh risks of COVID-19 with risks of patients remaining or waiting on the transplant list, because this would impact mortality. So what are some of the measures taken by the transplant centers? The first one would be to defer living or donor transplantation, which is considered an elective surgery. About 66% of the 118 transplant centers reported stopping all living donor surgery earlier in the year, based on a survey conducted in May 2020. Defer deceased donor kidney pancreas transplants, and only urgent transplants will be performed, especially if your transplant center is in an area with a COVID-19 surge. So there are over 400 published articles in solid organ transplant alone, including case reports, single center case series, and reviews, which is a lot of data. I think one of the big questions that we do need to answer, and we face a lot, is does immunosuppression directly imply a high risk of severe COVID-19 and mortality? I would say, as you know, all immunosuppressants modulate host immune responses, but the net state of immunosuppression of a host depends on their comorbidities, the type of transplant, the type of immunosuppression agent, if they've been treated for rejection or not in the past few months. And most immunosuppressants by themselves cause lymphopenia, which is a risk factor for severe COVID-19. So some of the early studies published were not helpful with answering these questions because they were smaller case series. Early in the pandemic, there was use of protease inhibitors, which causes drug interactions with calcineurin inhibitors like tacrolimus and causes toxicity. There was aggressive withdrawal of immunosuppressants causing graft rejection and failure. And they weren't helpful in answering the question about the role of immunosuppression. Coming to some larger studies which provided more information, a report from the French Solid Organ Transplant COVID Registry, which included 279 kidney transplant recipients. Patients were diagnosed with either PCR or imaging findings. 87% were hospitalized, and all of them had a lot of comorbidities. As this was in March and April, about 25% received hydroxychloroquine, azithromycin, and all the immunosuppressive drugs. Antimetabolites were the first to be stopped, and about 70% had them stopped, and then followed by calcineurin inhibitors, but further breakdown was not provided in the study. What they did conclude was that the overall mortality was 23%, and no conclusions could be drawn on the beneficial or detrimental effects of immunosuppressants. They found that factors associated with severe disease were BMI over 25, clinical presentation of fever and dyspnea, and factors associated with mortality were age over 60 and cardiovascular disease, also dyspnea on admission. Coming to another large multi-center study, this is from University of Washington. It included more than 50 transplant centers with transplant centers from within the US and internationally, and 482 patients, which is a big cohort, I think. There were kidney, liver, heart, and lung transplant patients included. 78% were hospitalized. Their immunosuppression management comes as close to something we recommend here, where antimetabolites were stopped first and discontinued in 53%, decreased in 10%, and all immunosuppressants discontinued in under 1%. The overall mortality in hospitalized patients is like a 20.5%. The factors they found associated with mortality were age over 65, comorbidities like heart failure, chronic lung disease, obesity, lymphopenia, and abnormal lung imaging. Again, there was no association with measures of immunosuppression or immunosuppressant agents. Some of the limitations of the study, though, are that the treatment regimens and management of immunosuppression change based on every transplant center and geographical region. So we cannot answer that question. It is a heterogeneous cohort, and the study relied heavily on clinician-reported cases, so that could be a bias. Coming to another lot study, the Spanish experience. This is basically a solid organ transplant around the world data here. It's a multi-center prospective study, included 778 patients. One of the few that had both solid organ and stem cell transplant patients. 89% were hospitalized. In this cohort as well, hydroxychloroquine was the treatment given to most of the patients, and adjustment of immunosuppression was performed. Overall mortality was 27%. And their subgroup analysis, they found no difference if they excluded stem cell transplant patients. And based on the survival curves, lung transplantation, age over 60, hospital-acquired COVID-19, and ARDS were the factors associated with mortality. And they found no difference in mortality with any type of immunosuppression. So as those studies were not very conclusive when it came to answering the question of does immunosuppression actually increase severity and mortality, another school of thought was to compare solid organ transplant and non-solid organ transplant patients. We have two different, the first school of thought that said the transplant status is not associated with mortality. There were 3 different papers published by 3 different groups, but none of them was statistically significant. Also, there were concerns that I found with their selection of patients and how in one of the studies, the solid organ transplant recipients were actually much younger than the non-solid organ transplant patients. The other school of thought is that higher mortality in solid organ transplant patients, but unfortunately, again, it wasn't statistically significant. My personal opinion is that if you consider the solid organ transplant patient as a whole, this is someone who has a lot of comorbidities that led to end organ dysfunction and them needing a transplant, which is why that, in addition to their immunosuppressive agents, puts them at high risk of mortality. So management, treatment recommendations do not differ from non-immunocompromised populations. Safety and efficacy of available investigational agents are not well defined, and transplant patients are excluded from most clinical trials because of being on immunosuppressants. Your takeaway from this table, which is a little overwhelming, is that remdesivir and convalescent plasma is safe to give to solid organ transplant patients. Initially, there was concern that remdesivir causes acute kidney injury, but now there have been a few case reports and case series that challenge that. Also, accumulation of the IV cyclodextrin, which was a concern, is less likely to happen since we only give 5 days of treatment with remdesivir. The early treatments like hydroxychloroquine, Kaletra, and other protease inhibitors were a real problem because of their significant interactions with calcineurin inhibitors and mTOR inhibitors. Thankfully, we don't use those anymore. And we still need more data on use of the monoclonal antibodies. So immunosuppression management, what is recommended is a severity stratified approach. So if they're asymptomatic with no risk factors, do not change their immunosuppressants. Clinical monitoring is recommended. And however, if they're asymptomatic with high risk, consider decreasing or stopping all antimetabolites. Most of this data is coming from expert opinion and management of other viral infections and the step-down approach of immunosuppressants that are used in other serious infections. Even in cases of severe COVID-19, you would continue low-dose calcineurin inhibitors, consider dexamethasone or IV steroids depending on local practices. So coming to the Miami Transplant Institute experience, this is unpublished data, and our brilliant transplant ID fellow, Anne-Marie Fernandez, helped me put this together. We had 132 COVID patients between March to September of this year, with a lot more in the last 2 months. The median age was 55, with 58% being male, 47% Hispanic. Comorbidities were hypertension, BMI over 25, and diabetes. Predominantly kidney transplants, which was 71%. On admission, they had 50% had moderate COVID and 27% had severe COVID. So our patients were sick on admission. Management, the decrease in immunosuppression occurred on 68%, which, as I said, was to stop antimetabolites like mycophenolate first, and then a stratified approach depending on how the patients progress. Dexamethasone was given to 45%, remdesivir to 38%, convalescent plasma to 21%, TPE's total plasma exchange, which was given to 22%, especially in patients who are in cytokine storm and not responding. That seemed to really help turn things around and avoid intubation. Our outcomes, mortality was 10%, which is lesser than most of the reported data out there. Graft loss occurred in 18%, and secondary infections of 17% were seen. In summary, solid organ transplant patients have variable clinical presentation, inflammatory markers, and imaging findings. Prolonged viral shedding is expected, more than 2 months, usually. Age over 60 and existing comorbidities, independent of transplant status, are a risk factor for mortality. Most of the published literature is outcomes in hospitalized patients, which I must say, based on all the data I presented and a systematic review conducted by our team here, was high. It was 80% or above. That's the percent of patients who get hospitalized. But data on asymptomatic or mildly symptomatic patients is lacking. In terms of management, we definitely need more randomized controlled trials to evaluate safety and efficacy of the available treatments in solid organ transplant patients. And for immunosuppression, we suggest severity-based reduction and complete withdrawal is not recommended. If you have time for light reading, consider reading this article that was published by Mohammed Raja and Dr. Ichiro Notori from our team. They summarized 215 solid organ transplants.
We're going to have to end. This will have to be your last slide, Shweta.
Yes, I'm actually done. Thank you.
All right. Well, thank you all for participating in a great grand rounds and an update on COVID-19, from heart to bone marrow transplant to lungs and everything in between, and solid organ transplants. Thank everybody for participating. Please stay well and stay safe, and we'll see you next week. Thank you.